Thank you, Gordon, for that very interesting and controversial topic. Great overview. Next, we have Wayne Campbell. Wayne is from Purdue University, and he is going to speak to you about that very important nutrient for older individuals, protein.
Good morning, everyone. It's certainly a privilege to be here, and I appreciate the hard work of all the people that put this workshop together. It seems pretty basic. We should have more protein for older people, and then I can sit down. The question is, do we really have the data to be able to support that scientifically and have a real sound recommendation for more protein? I'm going to focus on muscle, but I would really encourage everyone to realize that we cannot just make dietary recommendations based on a single organ. And whether or not, and protein has, for many good scientific reasons, been really a muscle-centric topic. And I'm going to continue that with my presentation. But please don't dismiss the idea that what we're really recommending is for a whole body response, not just for muscle. So as we all know, the recommended dietary allowance established by the IOM back in the early 2000s is 0.8 grams per kilo for all adults, both men and women, young and old. There are other recommendations out there that are often mistaken for RDAs or DRIs, but they are not. They are nonetheless recommendations for higher protein intake, notably in athletes, but also notably in older individuals. And I'm struck by the numbers that are here that often are somewhere between 25 and 50% higher than our current recommendations. And then there's always the discussion about what is apparent healthy versus chronically healthy. It's really important to realize that the current RDAs are not based on any functional outcomes. They're based on nitrogen balance data. And therefore, they're based on not only a set of physiological measurements, but also on mathematics on how to calculate those data. And I emphasize that because one of the questions is, are there alternative ways to look at the nitrogen balance data? This is the traditional way that has set our EAR and our RDA, and are currently the recommendations not only here in the United States and Canada, but internationally as well. Do these data apply to older individuals? The largest study, which was of the nitrogen balance type that was done actually in my research lab, and we actually confirmed that indeed there are no apparent differences in protein requirements for young men and young women versus old men and old women, and that the data are largely consistent with the current EAR of 0.66 grams per kilo. However, an alternative way of looking at these data are based on not so much new data as much as different mathematics. And Professor Rand, who was the lead author of the original the analyses that is set for the current RDAs, said that there's a biologically more realistic equation that may be a better approach. He concluded that that approach was premature, but other people, notably Humanian and colleagues, have looked at this, what's called a biphasic response, and they come up with an EAR from essentially the same data that is about 50% higher. And that therefore the RDA goes up by about 25%, simply by the mathematics. But none of this is physiological. However, so we looked to other techniques. There are data now emerging from what's called an indicator amino acid oxidation technique that have been done initially in young men. And basically, you feed people different amounts of protein or amino acids, and you come down to the amount of protein intake to meet their need for synthesizing proteins and limiting oxidation of proteins. And you'll see that it was about 0.93, which is very similar to that biphasic response. We've now done 3 studies in older and elderly individuals, and you'll see that there's no difference in requirements based on age. But it's higher than the RDA. So the nitrogen balance data really, and the kinetics data consistently show that aging does not affect daily dietary protein needs. But newer data bring into question the accuracy of the current EAR and the RDA for adults of all ages. And this is often lost in the discussion. If older people need more, is that a reflection of changes in need, or that the current RDAs are underestimated for everyone? Now, so with respect to muscle, though, it may be that there are age-associated differences. These are data from a recent analyses of acute feeding studies, where they're looking at the amount of protein in a meal versus the rate at which proteins are synthesized in skeletal muscle. And what they compared the older men and younger men. And what they found is that yes, as you increase protein from fasting and then start to eat, more protein that you eat in a meal, you get a higher rate of synthesis of skeletal muscle proteins. This occurs both in younger and older adults, but the point at which you maximize the rates of synthesis takes more protein for the older adults than for the younger adults. So it's not so these data really show 2 things. One is that the maximum rate, you can ultimately achieve it. There's no effect of aging on the maximum rate of protein synthesis in muscles, but it might take you a little bit more protein in a meal to get there. So for the remainder of my talk, I really, we've talked about the nitrogen balance data, we've talked about the isotope kinetics data, but ultimately what we need to do is to find functional outcomes to be able to base protein intakes. Protein intakes right now are based on how to be able to prevent deficiencies and inadequacies, but not necessarily with outcomes that are more is better, and is it? And so those can relate to body composition and muscle size, among others. In my lab, we actually have looked at the transcript profiles, the genetic profiles of skeletal muscle in people that have younger and older men who have consumed very defined amounts of protein that span the range of adequacy from 0.5 grams, 0.75, which is very close to the RDA, or 25% higher than the RDA at 1 gram. What you see, this is a cluster of 159 transcripts that are associated with protein catabolism or breakdown. And what you see is that the expression of those transcripts goes up markedly when you eat an inadequate amount of protein. Your body is catabolizing muscle in order to get, because it doesn't have enough substrate and it needs to draw on. However, what you see is that there's no real difference between the RDA and 125% of the RDA. In contrast, when you look at the transcripts that cluster for muscle and organ development, an anabolic effect, you see that indeed there's no difference here, and then, but higher than the RDA, you get an increase in expression. So to me, these data actually very nicely show that the RDA is achieving what it is designed to achieve, which is to prevent deficiencies, but not necessarily to be a quote-unquote optimal amount. And that may perhaps, in the promotion of anabolism, more might be better. But is that true? Reinforcing that not enough is bad. These are data from Castaneda et al. From back at Tufts University that clearly show that if you are eating about 56% of the RDA, so clearly an inadequate amount, very rapidly in postmenopausal women. You lose muscle, you lose lean body, you lose muscle size and strength. Just inadequate is bad, and you're going to actually compromise muscle function. We went back, we also, some of my work has been to actually look and see, well, what about the RDA? And so we actually have a 14-week controlled feeding study where we fed everyone the RDA. Some of the people were sedentary, and some of the people actually performed resistance exercise training. And what we have found, though, surprisingly, was that when people were eating the RDA with an energy balance, they're not losing weight, they gained body fat and they lost fat-free mass at the RDA level over 14 weeks. But, and indeed, in the people that were sedentary, their muscle mass, and these are computed tomography scans showing that the sedentary group lost skeletal muscle when they were eating the RDA. But it did not prevent people who were performing resistance training to actually hypertrophy muscles that were trained. So again, in that marginal state, but which is exactly what the RDA is designed to do. Earlier, Dr. Houston's data was presented on her wonderful work on a prospective study of several thousand older individuals and looking at protein intake. Overall, the conclusion was that participants that consumed the most protein lost less lean body mass and less appendicular lean mass than those in the lower protein intake. But perhaps the devil's in the details with that study, because the people that were eating the lowest quintiles in this were actually eating less than the RDA. So while more might be better, what these data really show is that inadequate isn't enough. And so it's a little bit challenging when people just use these data to support more is better, when in actuality what it's really showing is not that. And indeed, if you look at people that are weight stable in particular, protein intake had absolutely no effect on changes in appendicular mass. It was only when people were stressed with an energy deficit, which would be a catabolic state, the people that were eating below the RDA actually then were losing muscle. In contrast, people that were were gaining weight were actually only when they ate the highest quintile. Well, what is high? In this case, high was only 1.1 grams per kilo. It's not the recommendations that are often out there for 1.4, 1.5, 1.6. It's making sure that you're above that 1 gram per kilo. These are data from my lab in looking at weight loss in older adults, men and women. We know that on average, as older adults lose weight, about 75% of the weight comes from fat mass, about 25% comes from lean mass. The question is, can you influence that change in body composition by how much protein you eat? And indeed, people that were eating a normal protein, which is about the RDA, they were losing actually about 30% of their mass as lean mass, whereas people that were eating about 1.5, 1.4, 1.5 grams per kilo actually cut it by a third. So yes. These are data from a meta-analysis that Dr. Kim in my research lab recently published, questioning in weight loss if postmenopausal women and older men, does a higher protein intake, help with the retention of fat-free mass in the body? And among all of these studies collectively, there is a modest but significant retention of lean mass, and when these data were expressed per kilogram of percentage of calories from protein, and when you look at it from a gram per kilogram basis, you get the same thing. So protein intakes above 1 gram per kilo help these people influence their body composition responses to weight loss. So then we turn to exercise. Exercise is really important for older people, and strength training in particular is recommended. Does more protein help in that in the response to exercise? These data are from a compilation of about a half a dozen studies that my group's done over the years. And what we see is how much protein people were eating chronically while they performed 12 weeks of resistance training. These are all older men and women. And what we observe is that changes in fat-free mass, anything less than about 1 gram per kilo, at least on the linear scale, was neutral or negative. And that you really needed to be consuming above 1 gram per kilo in order to get a net anabolic response. These are data from that we just published looking at the amounts of protein that a cohort of several hundred middle-aged and older overweight and obese adults, when they consumed nutritional supplements, which often people are recommended to do, and they performed exercise training for 9 months. And what we observed, though, is that the groups that consumed chronically, their total protein intakes were less than 1 gram per kilo. They actually gained some weight, and they, compared to the groups that ate more protein, who maintained their body weight. And the reason everybody hypertrophied their muscles as a reflection of increases in lean mass and appendicular lean mass, the difference was not in the capacity of these people to respond to the exercise from a muscle enlargement perspective, but differences in their body fat. And again, one other point that I want to make, which I think is very important. There was no advantage to eating more than 1.2 grams compared to 1 to 1.2. And so there's been several groups over the last couple of years that have gathered scientific experts in the field to look at these issues about protein needs and overall health. Two of them I'll indicate here. The ProTage study group put out a report in 2013, and the European Food Safety Authority put out a report in 2012. They looked at essentially the same data, and they looked at outcomes related to muscle and body composition, insulin sensitivity, bone mineral. What's striking to me is that how different they approached the conclusions. And I think that this is a reflection of how do we go from what is already established as a recommendation, the DRIs, and what level of scientific strength do we have to change a recommendation? In this case, this group considered the data and recommended that indeed, if you have protein intakes greater than the RDA, that you're going to lower the risk of frailty and improve muscle mass and function. This group, with essentially the same data, said those data are out there, but they themselves are not scientifically strong enough to overcome the data that we have right now that we set our current intake needs on. And that also followed for body weight and glucose control, bone mineral density. This group was ready to make recommendations that change suggested intakes for older individuals. This group said, wait a minute, the data, it's intriguing, but it's not strong enough to actually change ourselves. That's where we are in the field. With my last few moments, I would like to just focus on the challenges that we have with protein for whether or not you actually make recommendations to people and whether or not we have the science to actually support those recommendations. And I'm using a statement in a recent review article on protein intake and the effects on muscle in hospitalized older adults. And the quote that was made in the conclusion of this review article was that focused efforts on using nutrition to maintain muscle health during hospitalization of older adults should be geared toward the quantity and quality of protein, equal meal protein distribution, and timing of protein supplementation. That sounds so prescriptive, as though we actually have the science to support those conclusions. One of the statements is what is a very commonly now recognized recommendation for older people to shift the protein intakes from what they usually consume, not much at breakfast, a little bit more at lunch and more at dinner, to actually having an even distribution of protein. And indeed, the scientific foundation for that is that the amount of protein in a meal is going to determine your response to synthesizing proteins in your muscles. And so if you look, theoretically, if you look at muscle protein synthesis rates in breakfast, lunch, and dinner, the more protein you eat progressively over the day, you're going to get a different amount of muscle protein synthesis. If you were to rebalance your protein intake so that you ate the same amount and more at breakfast and lunch and a little less at dinner, and in the case of hospitalization, if you also then supplement with leucine in between meals, you're going to be maximizing muscle protein synthesis throughout the day. Are there data to support this theory, which has been now presented for the last 6, 7, 8 years? The authors said in the next sentence of their conclusion, while they've made this prescription, additional questions need to be addressed before nutritional interventions are readily adopted in the clinical setting. So even though they've made this very prescriptive recommendation, they acknowledge that it really shouldn't be put into practice yet. Yet we all know that this is out there. People are making a lot of claims about this, and manufacturers are gearing their products about it. So what do the data show us? Within-day protein patterning and muscle protein synthesis, there have been 3 published studies so far. The conclusion from one of them is that yes, balanced protein works to increase muscle synthesis. Another one says no, and another one says, well, it doesn't work if you've got an energy balance state, but it does work when you're in energy restriction. That's the entirety of the data for acute feeding studies. Very mixed. And so then we go, well, what about the long-term data? Can we actually show that a redistribution of protein throughout the day is having an effect on maintaining muscle mass in elderly people? We don't know. So in summary, the current recommended dietary allowance for protein based on short-term nitrogen balance prevents aggressive muscle catabolism in older adults, but does not maximally promote muscle anabolism. Protein metabolism and muscle health and function outcomes data are slowly becoming available to aid scientists in setting our DRIs for protein with an emphasis on older adults. And these data should be critically and systematically evaluated to update our DRIs for protein. And lastly, the enthusiasm for prescriptive use of protein to promote the retention of muscle mass and function in older adults must be supported by high-quality longitudinal research, not just theories, hypotheses, or extrapolations from short-term studies. And with that, I'll end, and I appreciate your attention. Thank you.